Welcome to this podcast from the Medical Journal of Australia. My name is Sam Hunt, the MJA's News and Online Editor. Today we have an important cardiology update discussing aortic stenosis and atrial fibrillation. Aortic stenosis is the thickening and narrowing of the valve between the heart's main pumping chamber and the aorta. It's a condition that commonly affects elderly Australians, with up to 10% of people in their 80s having the condition. And once symptomatic, aortic stenosis has a poor prognosis if left untreated. Atrial fibrillation is a type of arrhythmia where the heart beats irregularly and often fast, and it affects about 2.2% of Australians. To find out more, I'm joined by Professor Stephen Worthley, an interventional cardiologist, and Associate Professor Hari Raju, a cardiac electrophysiologist. Both are with Macquarie University Hospital, part of MQ Health, which sponsored this podcast. Professor Worthley and Associate Professor Raju, thank you both so much for joining me today.
Sam, thanks for having us.
Thanks for having us, Sam.
Professor Worthley, I'll start with you and let's discuss aortic stenosis first. Can you take me through who is affected by this disease and can it be prevented?
Sam, they're good questions. It is something that is really concerning to people. And let me start first with the prevalence or how much of this condition's around, because people are very aware about coronary disease, heart attacks, stroke, obviously cancer at another piece. But valvular heart disease has been a little bit misappreciated as in terms of how frequent it happens. First of all, what it is the aortic valve is the major outlet valve of the heart. As we get older, it starts to thicken, harden, it becomes calcified, and so that restricts the opening of the leaflets, and it means the heart's under a greater pressure to be able to pump blood around the body. As it becomes more severe, it can cause breathlessness, blackouts, even heart failure and death. And so whilst I mentioned aging is actually probably the most important phenomenon that causes and leads to this thickening and hardening of the aortic valve, but some other conditions such as high blood pressure, obesity, diabetes, have been associated with aortic stenosis. But it's common, Sam. So we know that about 1 in 20, so up to 5% of people over the age of 65 will have moderate or severe aortic stenosis. In fact, 1 in 3 people over 65 will have some even early thickening of their aortic valve. But that even increases significantly to those over 80, where then 1 in 10% of people over the age of 80 will have moderately severe aortic stenosis. So meaning that they need some form of treatment. And just quickly to that point you asked, what can we do to prevent it? Sadly, Sam, not very much. We know I mentioned that aging is the most important phenomenon, separate from a very small percentage of people that may be born with an abnormal aortic valve, such as bicuspid aortic valve conditions. But although obesity and diabetes and high blood pressure have been shown to be associated with it, we've never shown that treating those conditions has led to any material improvement or restriction in the development of aortic stenosis.
And Professor Worthley, let me ask you from a primary care perspective, for general practitioners who may be listening to this podcast, how is AS initially detected? And what are some monitoring steps that can be done as a first line of defence?
The first thing is get the stethoscope and dust it off, because actually aortic stenosis is normally very easy for us to hear. It's probably the most audible and easily detectable murmur in listening to the heart. But ultimately, the easiest way for us to diagnose it is to do a non-invasive test called a transthoracic echocardiogram. It's a heart ultrasound, Sam, and it's very accurate identifying the problem. But even separate from picking it up as a murmur, any of our patients that have got problems with breathlessness, even blackouts, chest pains, which sometimes can mimic coronary disease, we should be thinking, could they have valvular heart disease? And so I would be recommending getting those patients an echocardiogram.
And Professor Worthley, at what point does a GP need to refer to a specialist?
The echocardiogram normally in all states, even in the rural areas, is very accessible. And so I'd be suggesting get that echocardiogram. They're readily available and you can refer for them. General practitioners can refer for them like they can for a chest x-ray or an abdominal ultrasound. And it's when you find a problem in the aortic valve that's a good time to go and see a cardiologist.
And Professor Worthley, when patients are referred to you, how far along on their aortic stenosis journey are they? And are you seeing patients that should have been referred to you much earlier?
Sadly, that is true, Sam. We still see patients that have had symptoms of breathlessness, blackouts, and chest pains that they've been putting up with for a number of years, and there's been a misdiagnosis. I think the awareness has been getting better recently, and so people are having a lower threshold to get a transthoracic echocardiogram in patients either with a murmur or with one or other of those symptoms. And so, we're picking up patients now, not only with the severe disease, but having it only just manifest recently. But even I mentioned that 1 in 3 patients that have got some abnormality of the aortic valve over 65 that we do know does progress with time. So they're the patients that we want to undertake some regular monitoring so that we can detect when they become severe and therefore get a definitive therapy for them sooner rather than later.
And Professor Worthley, let's turn now to treatment options. What kind of treatments are you usually looking at?
Sam, it's pretty straightforward because I mentioned it a little earlier. Sadly, there aren't any lifestyle changes or medications that have been shown to retard the progress of aortic stenosis. Once it's severe and causing symptoms, one of 2 options are the definitive therapy. Classically, that's been in the past surgical replacement of the aortic valve. That is open heart surgery, stenotomy, and obviously has some recovery, but it is a definitive treatment for aortic stenosis. More recently, we've had a minimally invasive approach called a transcatheter aortic valve implantation, where through the femoral artery, we can, using X-ray guidance and ultrasound guidance, replace a new valve within a stent frame, the old damaged valve. And the evidence has been emerging that less invasive approach, which is an obvious one for those patients at higher risk for surgery, is actually still a very good option now for even the lower risk patients.
How has treatment evolved? You've been in the game obviously a long time. Has the improved treatment overall enabled better outcomes, or are we still seeing the disease being caught perhaps too late and treatment options not necessarily being able to be applied?
The advances have been made in 2 areas. One, I do think that there is an increasing awareness of the frequency of aortic valve disease in the community. And I think podcasts like this are a great opportunity to continue to make sure that message is heard. But secondly, where we have seen a major advance is that minimally invasive. It's often shortened to TAVI or TAVR. That stands for transcatheter aortic valve implantation or replacement, where we can now fix a damaged aortic valve with an endovascular procedure. Patients are discharged the next day with now surgical-like results, where the benefits of this therapy are now being able to be distributed more broadly and widely to not only just the high-risk people, but even younger individuals at lower risk for surgery.
Associate Professor Hari Raju, I'll go to you now. You've been listening to all of this. How important is wraparound care and having a multidisciplinary team approach when undertaking these kind of surgeries and ensuring the patient journey and the patient's looked after?
So actually, aortic stenosis is a really great example where multidisciplinary care is really critical. So as Professor Worthley alluded to, many of these patients are elderly, they may have multiple comorbidities, and often the decision about definitive care being transcatheter or surgical should be made alongside a general cardiologist, an interventional cardiologist such as Professor Worthley, a cardiac surgeon, and often other individuals, including perhaps primary care physicians who know the patient well, and maybe even support from geriatricians who obviously are very familiar with managing individuals with multiple comorbidities. And that's just medical individuals. There are also often in these MDTs also other health professionals, including specialist nurses who have specific expertise in this particular field, rehabilitation individuals who can help with recovery. And so this is really a great example of how multidisciplinary care is critical to outcomes in individuals.
And Associate Professor Raju, I'll stay with you now. Let's turn to atrial fibrillation. How is AF usually identified?
Atrial fibrillation is the commonest sustained abnormal heart rhythm in the world, and it's largely, as with aortic stenosis, a problem of aging. Having said that, it is generally most commonly identified incidentally. And that is people who are asymptomatic, who are undergoing, for example, an ECG because they presented to their emergency department with a non-cardiac illness. They're having an ECG in preparation for a non-cardiac operation. That's actually the commonest way that it's identified. Having said that, there are individuals where they present with symptoms and signs of atrial fibrillation, and although most individuals and certainly most doctors associate abnormal heart rhythms with palpitations, atrial fibrillation can also present with breathlessness, fatigue, low energy, rarely chest pain, but it can present in many different ways, and it's important to keep an open mind in that regard. Having said that, the diagnosis can only be made following an ECG.
And you mentioned a lot of that detection occurs when you're looking for something else. Does there need to be more proactive, specific screening for AF?
That's a great question and currently fairly controversial. So there is a spectrum of screening options for atrial fibrillation. We are increasingly encouraging middle-aged and older individuals to be screened for risk factors for vascular disease or cardiovascular disease with blood pressure checks, and that's an opportunistic mechanism to screen also with a pulse check by your primary care physician or your practice nurse, and a lot of automatic blood pressure machines will actually alert you to the presence of an irregular pulse that might be indicative of atrial fibrillation. Beyond that, we have the ability now for more prolonged heart rhythm monitoring. That's where the controversy comes in, because unfortunately, although we know that atrial fibrillation has negative prognostic implications specifically with respect to stroke, actually the data that does exist from continuous monitoring of individuals with a cardiac implantable electronic device, so that is devices like a pacemaker or an implantable loop recorder, suggests that unless you have episodes that exceed 24 hours in duration, your excess risk of stroke is fairly small and perhaps negligible. And so you have a competition there between identification of short-lived episodes of atrial fibrillation, which may not be meaningful, versus the potential to prevent stroke in those individuals who have longer episodes.
And Associate Professor Raju, I want to ask you about smartwatches. We see them being advertised with atrial fibrillation capability. What's your professional opinion on them?
Sure. So as an electrophysiologist, I'm actually a big fan of those devices in other scenarios. Atrial fibrillation screening, that is trying to identify it in individuals with no symptoms that have been attributed to atrial fibrillation, is again a lot more controversial. And whether I like them or not, the reality is they are here. People are purchasing them, they are available to the consumers, and everybody in the world probably thinks that identifying a heart problem early is good for you. So I don't think that they're necessarily bad, but they are probably not at this stage evidence-based in that role. I do think it's worthwhile people understanding how they work. The majority of these algorithms work on a PPG sensor, which is, for doctors, they'll be aware of pulse oximetry. And the mechanism that smartwatches use to identify atrial fibrillation is basically the same. And they have an internal algorithm that determines is it regular or irregular. And most of the published algorithms will have sensitivity and specificity that exceed 90%. But again, I will reiterate that you cannot confirm the diagnosis without an ECG recording or at least a single lead rhythm strip. Actually, there are now 3 smartwatches that are approved by the TGA here in Australia for recording single lead rhythm strips. So that is possible that you might identify atrial fibrillation from a consumer device that is approved by the TGA for medical use.
And now a question for both of you. Perhaps I'll start with you, Professor Worthley. What is your first clinical priority for atrial fibrillation?
The first thing that I'm worried about really for patients that are presenting with atrial fibrillation is what is their risk for something that could be catastrophic. Whilst the rhythm and the symptoms or no symptoms, as Hari mentioned, that they're concerning for how people feel. What we worry about is the fact that atrial fibrillation is associated in some patients with an increased risk of stroke and other thromboembolic episodes. And look, we've got some markers that can help us understand what that risk might be. For example, patients that have got concomitant heart failure, hypertension, diabetes, God forbid they've had a prior stroke already. We know that they are at an increased risk. And the more of those factors you have, the greater that risk is. So assessing that feature for these patients, understanding whether they should be on potentially some blood thinning therapy is probably my most pressing piece. But as someone like Hari, who's as expert as anybody in this, understands, there are the other pieces around whether you should be trying to suppress this because patients are having symptoms or not. They're the other features around how you manage them.
As has been described, the CHADS-VASc score, which includes those risk factors, is really important and well published, and most doctors can assess that. I think the other thing to say is that in atrial fibrillation, that 5-fold increased risk of stroke is not meaningfully addressed by aspirin, which a decade ago was certainly being recommended for individuals with a relatively low risk of stroke. And so in the modern era, your choice is essentially between a non-vitamin K antagonist or nothing, not aspirin. Aspirin actually has a net negative outcome for individuals. It's actually worse than nothing because of the bleeding risk. So that's certainly, as Professor Worthley has explained, that is the priority because of the prognostic implications for patients. And then the next thing is to try and make people feel better, which is largely where someone like me comes in. Most doctors are perfectly capable of making decisions about stroke prevention.
Let me ask you about atrial flutter. Where does that fit in the context of what we've been talking about?
So atrial flutter is a regular short circuit within usually the right atrium, whereas atrial fibrillation is a completely irregular, chaotic rhythm from largely the left atrium. Having said that, they are close cousins. They share common triggers and common risk factors, and are both associated with that increased risk of stroke and have a similar presentation with respect to symptom issues. And the other thing I will say is that atrial flutter from a heart rhythm point of view can be more readily dealt with by procedures such as ablation. But even if you completely abolish atrial flutter, individuals affected by atrial flutter carry a 5 to 10% annual incidence thereafter of developing atrial fibrillation. So I guess to summarize, they're not identical, but they're close bedfellows and carry similar risks and presentations. But it is important that if you're addressing them, that you address them together.
And let's zoom back into atrial fibrillation. At what point do some patients just have to accept that they have the condition?
That's a really great question. And actually, one of my personal bugbears is that patients are often told, this is just AF, you're just getting older, you put up with it. And the reality is that there are very few individuals where that is an appropriate response. I feel as a doctor that we can prevent catastrophic health events and we can make people feel better. And so almost everybody with atrial fibrillation has a choice between conservative surveillance approach, you just wait and see, they're feeling okay. They have choices of a number of tablet options to either slow their heart rate down or prevent atrial fibrillation from occurring in the first place. But they also have interventional approaches, and depending on their other comorbidities and perhaps their age, that might be an ablation journey or a complex ablation journey, which is not a cure for this, but is over twice as effective as any tablet treatment. And for some individuals, a pacemaker-related solution, sometimes alongside a simple ablation, is a more appropriate choice than the complex ablation journey. But that's really a conversation for someone like me to have with a patient. And I would say that one of the other priorities that should enter clinicians' mind when they first meet somebody with atrial fibrillation is, have I given this patient all of the choices available to them to make them feel better? And if you haven't, then rethink that and potentially consider sending them for a specialist opinion.
And let's turn to a different point now. Professor Worthley, what level of health literacy are you seeing amongst your patients?
There's always room for improvement, Sam. That is absolutely true. Although I have seen over the course of my career a real change in, I'll call it ownership, awareness, and also seeking information from other alternate sources, whether that be the web, social media. It's growing. Obviously, it grows more in the younger generation, but the younger generation are being more actively involved in the management of their parents and grandparents. So, yes, we've got a way to go. So I think podcasts like this, for example, are a good way to help address that. But it is definitely, I'm seeing more ownership of patients in their health journey.
And Dr. Raju, what are you seeing?
There's certainly a growing number of people who not only expect but fully anticipate that they be the center of the conversation about choice for their health. So that's what I mean when I said that patients have options for treatment of surveillance or tablets or an interventional approach of a variety of different options, but ultimately they expect information. They will get some of that directly from us as specialists or subspecialists. They will get some of that from primary healthcare. They will get some of that from, other sources that may include their personal friends or other family members. But ultimately, they make a decision based on the information provided. And the proportion of individuals who now will say, as historically used to be much more common, you're the doctor, you know best, tell me what I should do, is falling. There certainly are still individuals who are in that category, but it's much less frequent. And I would say probably under 20-25% of the individuals that I see in my practice.
And now to wrap up, what are some top tips that you would give to GPs listening to this podcast? Professor Worthley, I'll start with you.
Well, I'll give two. The first of all is, I hope you've sensed it or felt it, that the familiarity or the similarity of risk predictors for what I've been talking about, aortic stenosis and atrial fibrillation. Age is a key factor, but obesity, hypertension, dyslipidemia. So look, lifestyle and living your best life is such an important part of cardiovascular health, as you're hearing here. But you know what? We could be talking to oncologists. It is actually quite a similar story. We can't do much about aging. It's better than the alternative, Sam. So, looking after yourself as best you can, and how, the primary care physicians, our GPs, are at the front line of this. So, it's an important conversation to have with patients. But look, secondly I'll say for aortic stenosis and valvular heart disease, have an awareness that it's actually very common. And so have a low threshold to, if you're worried and when you listen to patients' hearts, or they've got any potential symptom that you think, get an echo test. It's so simple, safe, and gives us the answer.
And Associate Professor Raju, your top tips?
Yeah, so I guess I would say that if you think someone has atrial fibrillation on clinical examination, get an ECG. They are literally available with no notice from any pathology service almost in the country. And send that with your referral. And the other thing, I would like to reiterate the advice about the importance of lifestyle and risk modification for cardiovascular conditions. And historically, for vascular disease, everyone kind of knows about smoking and high blood pressure, but atrial fibrillation is well established that it is associated with obesity, alcohol intake, sleep apnea, and inadequate exercise. And primary care physicians are in a pretty unique position, knowing their patients well, to A, identify those, and B, try and act on them. And you can let your patients know that treating those risk factors will reduce their burden of atrial fibrillation and make them feel better, which is a pretty compelling reason to act, even if you don't know that, even if you're not so worried about what might happen a decade into the future, you know that you have atrial fibrillation today. You can lose 10% of your weight and turn yourself from having atrial fibrillation 100% of the time to then almost negligible paroxysmal burden. You can make a big difference, and GPs are in a position to reinforce that repeatedly.
Professor Stephen Worthley and Associate Professor Hari Raju, thank you both so much for joining me today.
That was a really great session. Thanks so much for having us on the podcast.
Been great. Thanks, Sam. Real pleasure.
My special guests have been Professor Stephen Worthley, an interventional cardiologist, and Associate Professor Hari Raju, a cardiac electrophysiologist. Both are with Macquarie University Hospital, part of MQ Health, which sponsored this podcast. You can find more podcasts on our website at mja.com.au or wherever you get your podcasts. Thank you so much for listening.